Hi, everybody. This is the recording for pain management and labor complications. So, when we start thinking about pain management, we start thinking about this very early on. Pregnancy is one of those times when we already can anticipate that there's going to be a pain component. And so we start teaching women about how they can cope with labor and birth early. And truly, we have tied that into preparation classes that can also teach a lot of other things and provide really great education about prenatal care, fetal development, nutrition, and a lot of other things as well. So when we think about pain in childbirth, this is something that is going to be just happening during labor, right? Once the baby's out, the pain very quickly improves. And so there's kind of a light at the end of the tunnel. The way that your patient perceives her labor pain is going to be different. There's a lot of factors that contribute to what we think about our pain. So true that that's happens even outside of labor, and that's why we say that a patient's pain is what they say it is. But there's a lot of different things that can affect the way they perceive it. So it can be past experiences, it can be their age, it can be what kind of support system they had, what kind of frame of mind they're in that day. Also, maybe how their baby's coming down, if the baby's putting pressure on different nerves and things like that, that makes pain in different places. Um, and so we teach women different ways that they can cope and things they can do to manage. We also can work with some knowledge that of things like gate control theory, where that's our central nervous system factor, where we can stimulate the brain to notice positive things instead of the negative things. And that's working on the idea that a nerve can only carry one impulse at a time. So if we're encouraging positive impulses, it's not carrying the negative impulses and things like that. So things like massage and stuff like that can be done working on that line of thinking. So a lot of what we do in labor and delivery is going to be geared towards non-pharmacological pain management until such time that she requests medication. And there's a lot of things we do here. So we're doing relaxation techniques, we're doing massage, we can do hot and cold, we can do water, breathing exercises, lots of different things. So here's just an example of some of those. I'm trying to see which ones I didn't already say. Counter pressure. So when we're thinking about what position the baby's in, if the baby's head is putting a lot of pressure on the nerves that are in her back, that doing counter pressure on her sacrum can help relieve pain in that area. Sometimes ambulation is a good tool for pain management. It kind of helps rock the baby into a better position. Effleurage, which is kind of light, gentle massage where they kind of stroke their own belly in a circular motion. Massage, I mentioned in relation to gate control theory. Sometimes we use aromatherapy, focal points, lots of different things here. Also, women can labor in a lot of different positions, and these are all going to be things that also help not only with maybe the descent of the baby and the progress of the labor, but it can also help with pain management. Like if she's having back pain, then doing a forward leaning position might feel better, and so on. Sometimes women are having so much pain, they're having trouble coping, they're having trouble focusing, and they can hyperventilate. When you hyperventilate, you blow off too much of your carbon dioxide. And when that happens, you start feeling dizzy and tingly in your fingers and numb around your nose and mouth. And so if you see this with your patient, we need to try to refocus and we need to try to help control that breathing pattern. And in order to to resolve the hyperventilation symptoms, we can have them cup their hands and breathe into this or into a moist washcloth, and that's going to help them rebreathe their CO2 and re-equilibrate to balance themselves out. Once we get to a point where they, some women never get to the pharmacological pain management point. Okay, they might do really great with non-pharmacological pain management techniques clear to birth. But once we get to the point that we're requesting pharmacological pain management, there's a few things we're considering for this. It depends on what we're going to be doing. If we're wanting to do like an IV pain medication, like fentanyl, Stadol, things like that, we need to time it with how close we are to delivery, because these medications do cross the placenta to the baby, and they can cause respiratory depression if the baby's born very soon after the medications are given. In an emergency, if you gave a medication and your baby was respiratory depressed, we could give the baby Narcan, but definitely we don't want to go down that path. So we're going to be mindful of where we're at on our labor process when we're using IV pain medications. And then it's also a good idea to push IV pain medications during the peak of a contraction, because we're getting less blood flow through the placenta during that moment. And so theoretically, then we get less medicine to baby. And then we have anesthesia. So our most common anesthesia for labor is your epidural. Your epidural goes into this space in the back between L4 and L5. It's the most effective for labor. And it is going to be probably the one that you see the most. We can do a couple other things. The other one that we see occasionally is a pudendal nerve block. The pudendal nerve block takes some numbing medication and they inject it into the pudendal nerve, which innervates the perineum. So if you have a patient that's gotten very far in labor, she's close to delivery and the head's coming down and stretching those tissues and causing a lot of pain. And we can't really give IV pain medication at this point, and she's going to deliver before we could give her an epidural. A pudendal nerve block might be a good choice for her. The spinal is similar to the epidural, except that it's going to put medication into the cerebral spinal fluid. It is used for scheduled procedures typically. But both your spinal and your epidural have the ability to cause hypotension. And the reason for this is because we see a vasodilation with the medication. Spinals and epidurals have no lasting effects on babies, so that's good. They can cause, they increase the fall risk, because that once we give that in their back, they cannot use their legs well. Okay. They also typically aren't able to void well with a bedpan, so we will normally manage the bladder for them. And so we'll put in either a Foley catheter or we'll do straight cath every few hours. As far as the hypotension, that is our biggest focus. So we're going to do a fluid bolus beforehand, before a spinal or before an epidural, to help support their blood volume and their blood pressure. So when vasodilation happens, their blood pressure doesn't drop as significantly. And then we are watching the blood pressure closely after delivery. And then after the spinal or the epidural is placed, then we're going to lay her down and have her tilted or completely on her left side to help promote perfusion to the placenta. Okay. The other thing that can happen as a side effect of a spinal or an epidural is called a spinal headache. So I think we have a picture. Yeah. So here's what happens. If we're placing an epidural, we're going into this epidural space. And so there's different layers. There's the dura and then the epidural space. And if we go into the epidural space, the nerve roots come out and travel through that space. And if we put medication in that spot, it bathes those nerve roots and provides for pain management. If you're placing an epidural and they accidentally nick the dura, then cerebral spinal fluid can leak out. And if that happens, that's where you can develop a spinal headache, and that's going to be a slow process. So we won't see the spinal headache till the next day. Typically your patient's already delivered and she's on mom baby or whatever. And that headache is very specific in that they feel it when they sit up, but if they lay flat, they feel better. And they can repair that with a blood patch where they actually put some of the patient's blood into that epidural space, and it makes a placeholder until the body can repair the hole. You can also see a spinal headache when they're placing a spinal as opposed to an epidural. If the needle, usually they use a tiny needle so you don't get a leak, but if the needle is bigger, sometimes you can still see it. So that's your spinal headache. Other things that we can do for pain management. Nitrous oxide. Nitrous oxide is something that they inhale. It's something you might be familiar with from like at the dentist's office. It causes a euphoria. They hold their mask themselves. They're in complete control of how much they choose to breathe of it. And it has a rapid onset and it can help reduce anxiety. It's not going to take the pain away, but it changes their perception a little bit. And then general anesthesia, this is going to be something that we do typically in an emergency situation. It's more difficult to intubate pregnant ladies, and so we definitely, anesthesiologists will try not to do general anesthesia unless it's absolutely necessary. For an induction of labor, so for an induction of labor, we are going to be considering the gestational age of the baby and the reason for why we're doing an induction. So the idea of an induction is to make the body contract before labor starts on its own, and to make the cervix dilate before labor starts on its own. And so we can do it electively. If we do it electively, we want her to be at least 39 weeks. Okay. And then there's other times that we are doing inductions for medical indications. So things like hypertension, diabetes, preeclampsia, stuff like that. When we're doing an induction of labor, we want to consider what our contraindications might be. So if we think about what could be a contraindication of an induction of labor, anything that should be a C-section, I shouldn't induce my patient. So if the baby's breech, if she has herpes lesions, if she has a placenta previa, anything that would, let me see if we have more. Here we go. Placenta previa, cord prolapse, abnormal, so breech presentation, active herpes, abnormal size, or structure of the mother's pelvis. So if the baby's macrosomic and the mom has doesn't have a gynecoid pelvis, she has the palatopoid pelvis that's flatter, that should probably be a C-section. I wouldn't induce that. Okay. But we would do it for things like hypertension, infection, placental insufficiency, fetal death, things like that. So when we're thinking about doing an induction of labor, what we want to do first is we want to assess the inducibility of the cervix. And so we can check the cervix and feel how dilated is it, how thin or effaced is it, how firm is it, what position is it in. The higher score that you get here, the more favorable the cervix is for induction. If you get a really low score, we should probably consider cervical ripening. Cervical ripening is going to be typically prostaglandins, but they soften and thin the cervix and make it more inclined to open. Okay. If I just give her Pitocin and I make her contract on a closed and hard cervix, it's like trying to push on a closed door. Okay, but if we use cervical ripening and we soften it and we open it a little bit with that, then we give her contractions with some Pitocin. Now we have a better chance of getting her into labor and getting her dilating. Okay. So non-pharmacologic ways to stimulate contractions. Walking can stimulate contractions. Okay. It also eases the pressure on the mom's back, and it adds gravity. So we can either have her walk or we can have her sitting upright to help gravity put downward force so that the contraction is putting pressure on her cervix. The other thing we can do is teach her how to do nipple stimulation. Nipple stimulation causes her body to release its own oxytocin, which is going to make the uterus contract. So these are things that we can do to help non-pharmacologically stimulate contractions. For augmentation of labor, what we're trying to do is we're trying to make the uterus contract and move forward on a labor that has started but isn't progressing normally. So we are considering, again, oxytocin for this. We can also, for augmentation, we can also consider an amniotomy, and that's where they break the bag of water. And when they break the bag of water, the head comes down on the cervix, and so then it's better applied so the contractions can be more effective. So oxytocin or Pitocin, okay? I use these terms pretty interchangeably. The body produces oxytocin on its own, and Pitocin is the synthetic form of oxytocin. Okay, so oxytocin or Pitocin is produced in the body by the posterior pituitary gland, and it stimulates the uterus to contract. The other thing that it does in the body is later when she's breastfeeding, it helps the milk to let down. And so that's kind of an important twofold thing, because then when she's breastfeeding, it helps her milk let down and makes her uterus contract, which controls bleeding in the postpartum period. Okay. Oxytocin is going to be our drug that's most commonly associated with adverse events during birth. So what I mean by this is we can stimulate the uterus too much. And so we have to be very careful with how we administer this. It can cause the uterus to contract too much, too strong, too long, which can cause decreased blood flow to the baby, which can cause hypoxia. It can cause placental abruption. It can cause a patient to need a C-section. So high-risk labor and birth complications. So these are all things we're going to consider that are high-risk labor and birth complications. Our version, this is something that is completely optional. All right. So if a baby is breech, that baby is going to be delivered by cesarean. If the patient would like to try to turn the baby to head down, this is the procedure for that. For this, it is typically very uncomfortable. Some women are able to agree to do it with an epidural, and then if it's not successful, they go straight to C-section and deliver the same day. Otherwise, they can do it and send her home and wait for labor to start. The way that we do this is we do a non-stress test. So we get a tracing on the baby and see how the baby's doing. They give a medication to relax the uterus. Okay, so we usually use terbutaline for this. And then they use the ultrasound to see where the baby's at and where the placenta's at. And then the provider manually turns the baby. Okay, risks for this is placental abruption and causing labor. So we will keep her on the monitor for several hours after aversion and make sure that we're not seeing any signs of an abruption and that the baby is doing okay. Perineal repairs. So episiotomies used to be very common. Episiotomy is if they surgically enlarge the vaginal opening. And so with this, the thought process behind it is if they cut, then it's a nice straight line to repair, where a laceration can be torn in all sorts of ways. But what they found is that oftentimes an episiotomy happens and the body still tears because it's going to create the space it needs. And so more often than not, we're seeing less and less episiotomies. For nursing considerations, the way that we take care of these patients are going to be the same. All right. So in order to try to minimize tearing of the perineal tissue, we can use olive oil during when the head's crowning, when she's pushing, and massage that tissue to help it to stretch. She can also do that at home even before labor. And then when delivery happens, then they will kind of grade what degree of laceration you have. So a first degree laceration is superficial. Oftentimes they don't even repair those. Second degree is going to get into the deeper tissues and muscle of the perineum. Third degree has that, plus it has an involvement of the anal sphincter, and a fourth degree extends all the way through. So if you have a third or a fourth degree, especially, we are really trying to minimize trauma to that area. And since we have some rectal involvement, it's really important that we are preventing constipation. So we are encouraging fluid intake. We are encouraging high fiber diet. We're giving stool softeners and probably laxatives, or like Miralax, something like that. We don't want anything in the rectum. So if she did become constipated, we wouldn't be using like Listerine suppositories or enemas. And we're teaching her how to use the peri bottle to keep the area clean, ice packs, and things like that. Forceps assisted birth. This is something that is really kind of starting to go by the wayside, I feel. A lot of providers are no longer, like the newer providers are no longer learning how to do a forceps deliveries, and they're doing vacuums instead. But a good forceps delivery sometimes is very indicated. So here's when we see assisted births with forceps or with vacuums. So if mom's been pushing for a long time, we have a prolonged second stage and she's exhausted. Maybe the baby's heart rate tracing is showing decelerations, and the baby is showing signs that it's starting to have signs of stress. If the baby's head is really low, sometimes it makes more sense to put the forceps on and help pull the baby from below than to go back into the operating room and do a C-section. And if the head's that low, it's hard to do a C-section, actually, to get down into where the head is and pull the baby back up and through the uterus and through the abdomen. So that's a time that they might use forceps. If we're using forceps, for mom, we have an increase of lacerations. And for the baby, we have an increase like facial bruising. And so it looks like this. So nursing consideration would be to empty the bladder beforehand so that we don't have anything up here in the bladder that's impeding our progress for forceps delivery. And then when the forceps are in place, then it's a joint effort between the mom and the provider that's pulling with the forceps. And so we help coach that push. Typically in this scenario, I also count it out so that both of them know when she's pushing. So once she starts, I count, and push 2, 3, 4, whatever. And the goal is to get to 10. And so that they are both working together and coordinating the effort at the same time. For vacuum assisted birth, this is another way to assist. You can see that instead of putting the forceps around the baby's head, this goes on top of the baby's head. And then they increase the pressure, and this is going to give them the ability to pull. This is more often what I see. This is more often what the newer providers are using as the vacuum. This is again going to be a time when maybe we have maternal exhaustion, we have fetal intolerance, we are close to delivery vaginally, and this is a better choice maybe than a C-section. If we try forceps or vacuum and we don't get the delivery, they're going to be a C-section anyway. So it's something we can try and see how it goes. We need to have a fully dilated cervix. It says no suspicion of CPD. So what that means is we don't think that we have cephalopelvic disproportion. We think the baby should fit through the pelvis without complication. Okay. Similar risk to mom as far as lacerations and hematomas on her tissue. For the baby, though, instead of the bruising on the face, a bigger concern that can happen because of the pressure that's happening on the scalp is babies can develop what's called a cephalohematoma. So cephalo is head and hematoma is a collection of blood. And so then that would increase the baby's risk of jaundice as well. So that is the kind of the considerations. Again, with this mom, we should empty her bladder beforehand. Cesarean birth. So times we would do a C-section. We kind of talked about this in relation to inductions, and not doing an induction if she should be a C-section. So breech or malpresentation. Abnormal labor. So if we've been trying to get her delivered and she's been stuck at 6 centimeters for 7 hours, that's an abnormal labor pattern. Inability of the fetus to pass through the mother's pelvis. So that is also cephalopelvic disproportion. It can also be macrosomia for your baby. Maternal conditions such as gestational hypertension or diabetes, active herpes, previous surgery on the uterus, fetal compromise, and placenta previa or abruptio placentae. These are all reasons to do it. For cesarean birth, we're going to anticipate our incision in the uterus to be in the low transverse part of the uterine muscle. And so it looks like A over here. And if they do this, then it has it heals really well and could potentially give them the capability of trying to labor on a future pregnancy if she would choose to. Some C-sections are elective. So elective C-section might be somebody like we know the baby's macrosomic, we know the baby's breech, we know mom has a placenta previa. Those are actually our scheduled ones. I apologize. Our elective ones are typically like known sexual abuse history, and things like that. She's choosing to have a C-section as opposed to trying to labor. And then we have C-sections that are unplanned. So maybe we have that prolonged labor that's not progressing, or we have fetal intolerance of labor where the fetal heart tones are non-reassuring. Maybe we have a prolapsed umbilical cord. Those can be emergency. Risks to mom, risk for infection, risk of injury to the organs, risk for thromboembolism. Risks for baby. So risk for injury. Okay, they're really careful with this, but it is possible to nick the baby with the scalpel. Risk for asphyxia and risk for respiratory issue. So when the baby's being delivered via C-section, they're not getting that same squeeze on their chest coming through. And so they can have some fluid still in their lungs. And if they have what we call an inadequate fluid clearance, it can take them some time to work that out. Okay. Nursing considerations. We're going to want labs done beforehand. Okay, we want to know like her type and screen. So if we have any bleeding issue, then they know right away what kind of blood products she would need. We're going to place a Foley catheter to keep the bladder empty during the surgery. She's going to get medications beforehand. So typically we'll give an antacid like Bicitra. We might give Pepcid. It depends on the facility and it depends on the anesthesia, what they want. We might give Zofran to help with nausea. And then she'll get an antibiotic because we're opening the uterus and because of increased risk of infection, especially we worry about at the site where the placenta was attached, infection developing there, which is called endometritis. Okay. After delivery, we're watching her vital signs. We're watching the dressing for signs of bleeding. We're still assessing her fundus and making sure that it's firm and that it's where we expect it to be in her lochia drainage. And then we're giving her kind of normal post-operative care and postpartum care. Obesity. So obesity is something that can definitely make a pregnancy high risk. It increases a woman's risk of thromboembolism. It increases her risk of needing a C-section. It increases her risk of having a hemorrhage. And if she needs a C-section and she's obese, oftentimes obese women have what we call a pannus that leans over the area that we want to do the incision. And so keeping that wound dry and clean is more difficult. These women also, your women that are obese also have a higher prevalence of comorbidities that increase their risk. So chronic hypertension and diabetes. If a patient has a C-section and then she's pregnant again, she might choose to try to deliver vaginally. If that happens, we're thinking about, we call it a trial of labor after cesarean or a TOLAC. If she's successful, then she has had a vaginal birth after cesarean or a VBAC. Risk with to try to TOLAC is uterine rupture. Anytime there's been an incision on the uterus, then there's an increased risk that the uterus can separate at that point. If that happens, that is really bad. It is very dangerous for moms and babies. Okay, so we have these moms sign a consent and in order to do trial of labor, and there has to be very specific things in place. So they need to have we need to have anesthesia in-house, we need to have a surgeon in-house, we need to have a NICU team available. There's a lot of things that have to happen in order for women to even be able to do a trial of labor. Dysfunctional labor or labor dystocia. This is what we consider a long, abnormal, difficult labor. And so when we think about this, we're thinking about our P's that we learn about our power, our passenger, our passageway, our psychologic response, mom's position. These are all things we're considering, like why are we not getting a good progress? So it can be a power issue. So then we can consider Pitocin. It can be a passageway issue, so maybe it's the pelvis. Maybe it's the passenger, so our baby. What position is our baby in? Do we have cephalopelvic disproportion? Do we have macrosomia? We can also be considering how mom's coping and how that can contribute to a labor dystocia or a dysfunctional labor. A precipitous labor, this is going to be kind of the opposite of your dysfunctional labor. So precipitous labors happen so fast, from onset to baby is less than 3 hours. And this is really hard for the mom and for the baby. There's not any sort of gradual buildup. It's just all of a sudden she's going and she's going hard. And when those contractions are so strong and so close together and lasting so long, that decreases our blood flow to baby. So risk of hypoxia for the baby. Also, as the baby's coming down and out quickly, they can have trauma to their head. Okay. For mom, she can get lacerations and hematomas on her bottom from the baby coming out so fast. Her uterus could rupture from contracting so hard and fast. And she also then has a higher risk of having a hemorrhage after delivery because now the uterus is tired and not really wanting to contract. Okay. This is sometimes precipitous labors just happen. But this is also something we can see with cocaine use. This is kind of a common thing that happens when moms are using cocaine. And also we can see this happen with a placental abruption. Also, on the flip side, we can see a placental abruption because of it, because uterus is contracting so hard and fast. So there's a lot of different considerations there. Premature rupture of membranes. We also call it PROM. This happens when the water breaks before she has gone into labor. And so this happens regardless of gestational age. So when we say premature rupture membranes, we don't mean that the baby's premature. We just means the water broke too soon. Okay. Now, if she is also carrying a preterm baby, she's less than 37 weeks, then we are preterm premature rupture of membranes. So that's PPROM. Okay. Risks if the water breaks before labor starts, increased risk of infection. That's the most common one. And the infection we worry about here is chorioamnionitis. So if we remember what we learned about the chorion and the amnion and those membranes that are surrounding the baby and the fluid, that's where we're thinking about the infection originating. And then it involves amniotic fluid in that whole area. Okay. The other big thing that can happen if the water breaks and the baby's not well engaged is we can see an umbilical cord prolapse. So that would be an emergency. If the cord is in front of the baby, that is an emergency situation. How we treat this is going to be dependent a lot on what her gestational age is, and if she's showing signs of infection. If she is preterm and she's not showing signs of infection, we might keep her pregnant and keep monitoring her in the hospital and giving antibiotics. If at any point she's showing signs of infection, though, then we should deliver. So infection's the greatest risk. Delivery is recommended after 34 weeks. So 34 weeks, even though term is 37 and up, 34 and up is going to be considered, those babies, they can call it late preterm from 34 weeks to 36 and 6, and those babies do pretty well. And then if we're earlier than that, then they'll try to keep her pregnant for a while. So expectant management, this is a time that they could try to assess pulmonary maturity. They could do an amniocentesis. They could look at the LS ratio. Truly, I don't see that happening a lot in practice, but that might be a consideration. If we keep her pregnant, we're giving her antibiotics. We're doing daily fetal assessments. So we're doing non-stress tests. We're also having her do kick counts. We're assessing for signs of infection. So fever. The signs of infection, I feel like, are on the next slide with chorioamnionitis, but we're thinking about fever and tachycardia for both mom and baby, uterine tenderness, foul smelling, amniotic fluid. If her baby is less than 32 weeks, we can use magnesium sulfate. And instead, we used magnesium sulfate for preeclampsia, if you remember. But in this case, magnesium sulfate can provide neuroprotection for the baby. So it can help protect the fragile vessels in the baby's brain. And so oftentimes we will consider magnesium sulfate for preterm labor and for preterm rupture membranes. Yep, there's our infection slide. So chorioamnionitis is the infection that we worry about. This can happen usually after labor starts, but it can happen if your water breaks early, like we just discussed. Risks for baby with chorioamnionitis is going to be infection or signs of respiratory distress syndrome. Risks for mom, it can cause a dysfunctional labor pattern, bacteremia, sepsis, stuff like that. Signs and symptoms, fetal and maternal tachycardia. So not just the mom's heart rate goes up, the baby's heart rate goes up in response to the maternal fever. Okay, we can see uterine tenderness, foul smelling discharge. It can have a purulent look to it. Okay, if she's infected, we are no longer trying to keep her pregnant. We're not giving tocolytics to help her uterus to relax. We are encouraging labor to happen, and we're giving antibiotics for treatment. Post-term pregnancy, labor, and birth. This is going to be when the pregnancy extends beyond 42 weeks, okay? Risks for letting the pregnancy extend this long. Once we're over 42 weeks gestation, we are seeing the placenta is not working as well. We're having more, what am I trying to say? We're having less amniotic fluid levels for babies. So we can see a couple things happening. We can see less blood flow to baby through the placenta. So we can see like late decelerations. We can see cord compression from the low amniotic fluid level. So we can see variable decelerations. These babies have a higher prevalence of having released meconium, so meconium stained fluid, meconium aspiration syndrome for baby. These babies also have had extra time to grow, so they might be macrosomic now. So if you think about what we talked about in relation to diabetic moms that have babies that are macrosomic, and we were concerned about the fit, we were concerned about birth injuries and things like that, that could apply to this as well. Okay, so we could be worried that we have an increased risk of shoulder dystocia, we have an increased risk of mom needing a C-section and things like that. Preterm labor and birth. Preterm is happening before 37 weeks. It is going to be dependent a lot on how early a baby is, how they do. Okay, we already said that 34 weeks and up, these babies tend to do pretty well. Those are considered our late preterm babies. Babies that are earlier than 32 weeks often have more difficulties. So those are also the babies we consider like doing magnesium sulfate for neuroprotection and things like that. We can also have babies that have a higher prevalence of growth restrictions, so they're smaller. And sometimes these are spontaneous births, but sometimes they're indicated. So we might deliver a baby less than 37 weeks if mom is really sick. Or maybe if baby has a condition too. So how do we know if she's in preterm labor? Ways we can predict. So if a patient comes in and she's preterm and she's contracting, there's different things we'll look at. We can measure the length of the cervix to see if it's thinning. We can do a fetal fibronectin test, which is a swab that looks at, it swabs by the cervix and it looks for the glycoprotein fetal fibronectin. If the fetal fibronectin test, it predicts who's not in preterm labor. So if it's negative, then that's more telling than if it's positive. Because if it's positive, a lot of things could make it be positive, but negative is negative, so that's good. The other thing that we are considering is for women who have had preterm birth before, they might be at risk of preterm birth again. So for preventing preterm birth for those women, they might get prophylactic progesterone, because remember, progesterone maintains a pregnancy. And so doing that can help maybe maintain a pregnancy where she may have had a loss before. Causes of preterm labor and birth. So our biggest cause of preterm labor and birth is infection. All right, so it can be the UTI, it can be genital tract infections, it can be those things. And that is especially primarily for our deliveries that are 30 to 32 weeks. Structural abnormalities can contribute to this. So there's a lot of things that can be happening, like bicoordinate uteruses and things like that. You can also have placental implantation issues, which we looked a little bit at previously. I feel like in week 1 or 2. So if they had unexplained bleeding in the first trimester, that increases their risk. Maternal stress actually can contribute. Overdistension of the uterus, so thinking about our multiples, or high amniotic fluid levels, allergic reactions, and a decrease in progesterone, which is why women who have had preterm labors before are a higher risk, so they can get progesterone prophylactically. How do I know if my patient is in preterm labor? So the thing is, guys, the most common signs we see for preterm labor is going to be pelvic pressure, dull backache, and uterine tightening. And anybody who's had a baby will tell you, I felt all those things. So trying to tease out, is this a normal discomfort of pregnancy or is this actual labor, is going to be the hard part. If a woman's worried enough to present with these symptoms, we definitely need to take them seriously. And we'll do our monitoring. We might go ahead and start prophylactically doing things in case she is going to change her cervix and deliver. So we might start antibiotics for her. We might start by giving her betamethasone. Betamethasone is a medication that helps promote lung maturity, but it works the best if we get 2 doses and they need to be 24 hours apart. So it really takes 48 hours to get to that highest effect. And so starting that early is going to give us the best, to give the baby the best chance. So we'll restrict activity, we'll put her on bed rest. We can suppress uterine activity by using medicines that are called tocolytics. And so that's where the It's Not My Time mnemonic, that's what it's reminding us what those drugs are. So indomethacin, nifedipine, magnesium sulfate, and terbutaline. We talked about nifedipine in relation to our preeclamptic patient because it's actually a medicine we also use for hypertension because it's a calcium channel blocker. Magnesium sulfate is something we gave in preeclampsia to try to minimize the risk of a seizure, but it also has that neuroprotective effects for baby. Terbutaline is something that we also use if we have a non-reassuring fetal heart tracing because the contractions are too strong. We'll use that in labor. We can use it here to suppress uterine activity. And then we see what happens. So we'll give her medications and we'll see if her cervix changes or not. Okay. Meconium stained fluid. So if the baby passes meconium in utero, then it mixes with the amniotic fluid. And so what we see is now the amniotic fluid has a green look to it. And when that happens, the thing we're really worried about is remember that the baby's body makes breathing movements and sucks in that amniotic fluid. And if that happens with the meconium in it, meconium is very sticky and it's going to impair gas exchange in the lungs after the baby's born and can cause pneumonia. Cord prolapse. So an umbilical cord prolapse, when this happens, we have the umbilical cord is below the presenting part of the baby. So this most commonly happens with when the water breaks, rupture of membranes. I think I have a picture. Yeah. So if you look, especially like at letter C, all right, so you can see how the umbilical cord is looped down into the vagina and it's in front of the baby's head. As soon as the uterus puts pressure on that baby, it's going to come down and compress the cord. Okay, this is a huge emergency because think about how all the baby's oxygen is coming through the blood through that cord. If we have pressure on the cord, we're not oxygenating our baby. Okay, and so the priority here, the biggest priority is delivery. But before we can get to the emergency C-section, we have to relieve pressure on the cord. Okay, and so that's what these pictures are showing us. In this picture, the nurse or the doctor is holding the baby, putting pressure on the head and trying to hold the head off the cord. This is usually the nurse, and this is usually whoever finds it is the holder. Because once you put your fingers in there and you feel a cord, you don't take your hand out. You push the head off, or if it's a case like D, you push the butt off of the cord as much as you can, and you hold it, and then you push for your emergency light for help. Okay. The other thing we can do is let gravity help us out. So truly holding the baby's head off the cord is hard. It's 2 fingers. And so we can put mom in position that lets gravity help us. So the second picture is the knee chest position. The knees are on the bed and the chest is on the bed. And you can see how gravity then helps rock the baby back. You still then can put your fingers in her vagina and hold the head as well in this position. The other picture here is a modified Sims position. Truly in practice, I haven't used this much. Typically what we do is either knee chest or more often we'll do Trendelenburg, which is here on the slide. And so extreme Trendelenburg points the head of the bed downward. And so that's still going to help rock the baby back. You can control the bed that way. You just push the button, it does the Trendelenburg position, and then you can still hold the baby with your fingers off the cord. Okay, so we're going to stay with the patient. Someone calls for help. We're putting pressure on the presenting part. We're putting the patient in a position to let gravity help take pressure off the cord. And then we're going back for a C-section. Okay, there are other things you'll see, like wrapping the cord in a sterile towel with warm normal saline. You can do that if the cord is protruding, but truly if the OR is right across the hall, I'm just moving towards delivery. But if this is something that happens and we're not able to move straight to the OR, that is something to do. It's important not to put the cord back inside the vagina because that can cause compression to the vessels, okay? And we're preparing for immediate delivery. Shoulder dystocia. So shoulder dystocia is another significant OB emergency. And this is something when we were talking about our macrosomic baby, how's it going to fit, risk for birth injuries, stuff like that. This is the one thing we're really thinking about and worrying about. And so what happens with this is that the head delivers and then the shoulder's not able to clear the pubic bone. So you can kind of see that in the picture here. Okay, so risks for this are things like macrosomia, pelvic abnormalities for mom. So if she has a history where her mom had a shoulder dystocia, her sister, whatever, that could be an increased risk for her. If she's had a shoulder dystocia before, risk of having shoulder dystocia again. All right. And so people that are at risk might just choose to have a C-section and prevent and not do this part. But oftentimes this is not something we predict. It surprises us. The head comes out, the shoulder doesn't deliver. Once this happens, we are on the clock to get this kid out. The longer it takes, the less oxygen to baby. So I will ask you for shoulder dystocia and also for cord prolapse. How long can you hold your breath? Because for every minute that this baby's putting pressure on their cord, we're decreasing their blood flow and we're decreasing their oxygenation. And same true with shoulder dystocia, because now the body's in the birth canal and there's pressure on the cord. And so every second, every minute that it's taking to get this baby out, we are decreasing our oxygen supply. Okay. So this is very stress inducing for everyone involved because time is oxygen. Things that we're doing to try to release the shoulder. We can do, the very first thing we do is called McRoberts. McRoberts maneuver, we push their feet back so their knees go back towards their ears and it tilts their whole pelvis. And when that happens, you can see in the picture how it changes the diameter. And sometimes that's all it needs to release the baby. Okay. The other thing we can do is suprapubic pressure. Suprapubic pressure is typically done by the nurse at the bedside. And we take, we put pressure on the mom's pubic bone like this to push the shoulder underneath. Okay, but if I'm putting pressure here, then I'm also risking breaking the clavicle here or breaking the humerus here by putting lots of weight here. Okay, but if it releases the baby, a broken bone's a lot better than a dead baby. All right. So those are going to be the main things that the nurse is helping with: McRoberts maneuver and suprapubic pressure. There's also a position change. We can switch mom to hands and knees, and that can change the diameter of the pelvis and help release. Otherwise, the provider might try to deliver the posterior arm. And so they'll reach underneath and kind of scoop that arm up and to change the diameter. And so that's not something that the nurse is doing, but they're still holding the leg back and kind of keeping that McRoberts position going on while the provider does that. So during this emergency, the provider typically is saying, this is what I want to try, and the nurse is facilitating the parts that they need to. We're also calling for help because I want my NICU team in there. I want an anesthesiologist, because that if we don't release the shoulder, then we might have to go to the operating room. And so I'm calling all my emergency people. And the injuries besides asphyxia, the injuries to baby: asphyxia, clavicle fracture, humerus fracture. The other one is a brachial plexus injury. And so these are the nerves that run between the neck and shoulder. And so when they're doing a lot of pulling to try to release the head, and they're doing this kind of pressure, then it's stretching all of this. So brachial plexus injuries are also a common injury for this. And then our uterine rupture is our other obstetric emergency. Uterine rupture happens when we have a separation of the tissues of the uterus. So if she's trying to TOLAC, she has a uterine scar, we have that risk. Okay. Also, if she's ever had any other surgeries on her uterus before, any other damage to her uterus before, it can increase the risk. If this happens, it can cause neonatal death. Okay. And so the other time that we see it besides TOLAC is going to be things like tachysystole. So we're making her contractions too hard or too strong, or maybe her body's doing that on its own. It can contract so hard that the uterus ruptures. If it's because of oxytocin we're giving, we need to turn it off. Okay. How we manage it depends on the severity, but truly we're probably doing the surgery and we're repairing it. And then amniotic fluid embolism, this is super rare, thankfully, but it can be catastrophic. This is an anaphylactoid syndrome of pregnancy, and it causes cardiovascular collapse and respiratory collapse. So a foreign substance from the amniotic fluid enters into the maternal circulation. This should never happen, but once in a while, cells get by and it happens. So things like that precipitous labor and birth, uterine rupture, some of those things can increase the risk of this. When this happens, we have to do CPR right now. This is a case where if she's still pregnant, we have to get the baby out right now. And everything is going to be aimed at the maternal resuscitation, and that's going to give us the best chance of the fetus surviving as well. So cesarean should be considered after 4 minutes for optimal fetal survival and to facilitate maternal resuscitation. And she's going to be bleeding everywhere because DIC happens. She's respiratory, maybe is apneic, like everything is bad with this. And so we are trying to fix everything. It's a true emergency. In order to actually diagnose an AFE, it is on autopsy. But if we have a woman that goes down this path and has all these symptoms and we manage to save her life, we can say, well, that was probably an AFE. And so that is the end of that. I hope you guys have a great day.